Kia ora koutou, good evening, everyone. Thank you very, very much for giving us the time this evening to present a beginner's guide to ACC for medical specialists. I'm Peter Burt. I'm a clinical advice manager at ACC and a medical doctor by training. I'm just going to hand over to my colleagues who are co-presenting this evening. Emma, first over to you.
Kia ora, everyone who's joined. My name is Emma O'Loughlin and I'm a health partner in ACC. So that means I liaise with some of the medical groups, the surgical groups and ACC and create, relationships between us both. In addition, I'm a physiotherapist and I'm an academic at the University of Otago where I convene the 5th year musculoskeletal medicine module. So I will hand over to Hamish now. Thanks.
Kia ora koutou katoa, ko Hamish Johnson taku ingoa. I'm the portfolio manager here at ACC for the secondary and tertiary services. So that includes the contracts like elective surgery and clinical services and radiology. So the contracts that a lot of you will work with. I'll hand over to Kylie.
Kia ora koutou, I'm Kylie Brown. I am the portfolio advisor working with Hamish and I'll be here today talking about how you deliver your services.
Good day, everyone. So just a bit of housekeeping before we get started. You'll see across the tools bar at the top a Q&A icon. If you have any questions during the session, if you could please put your question in that platform, and then Hamish will present those as we need to, either or attend to them as we go through the session. This webinar will be downloaded, so you will be able to get the webinar and the slide deck at the end of the session. And if you have any content that you would like more information about, or further different platforms or content for us in the future, or things that you'd like us to present, if you could put that in the feedback as well, and we will endeavour to try and do more content for you in the future. But once again, thank you very, very much for attending this evening. This slide tells you what we're going to be covering tonight, and the key bit really is about why we want this information. So we need, the more information we have around the cover and causation and the link between the accident and the need for which you're requiring treatment, the smoother it is for that Kiwi who needs the support. We'll also be presenting you with some other things in relation to medical certification and cultural responsibilities, as well as some resources at the end. So I'm going to hand over to Emma, first of all, who's going to talk to you about ACC in general and then about cover and causation. So over to you, Emma. You're on mute.
Great start. Perfect. Thanks, Pete. Sorry. So first of all, I'll just give a quick overview of ACC and what we do. So what is ACC? Well, we're a Crown entity, which basically means that we're part of government and we're set up to deliver a range of services and make some of our decisions independently. So when someone gets injured after an accident, we provide no fault personal injury cover. And that's both for Kiwis and for people who are visiting the country. And what we do is pretty clearly set out in legislation in the AC Act. So what do we do? Well, in summary, we contribute towards medical treatment, so from yourselves, and rehabilitation. And we provide financial support to people who can't work after their accident, if they were in work at the time of their accident. Before that, we have our injury prevention team really try and educate people to prevent those injuries in the first place, such as with the recent Have a campaign. And finally, we also have a few different teams which work with communities which try and improve people's understanding of health. And that in turn the idea is that it would reduce the number and impact of injuries when people have them. And so you might be wondering how we pay for all this. And so in New Zealand, we all pay for each other to basically keep the ACC scheme running. And we're funded from levies, so 3 separate levies, one from motorists, one from workers, and one from businesses. And then the government steps in and basically pays for non-earners and visitors. And all that money together is reinvested into an investment fund, which then pays for the future cost of the scheme, and the injuries that happen now, their future costs over the lifetime. So as Pete mentioned earlier, it's super important for yourselves and us to really understand what ACC can cover and how we really think about causation. So that link between the accident and what we can cover. And what does cover mean? So cover basically means whether a claim, so the submission that the client submits on their ACC 45, if that meets legislative criteria. So does it meet legislation criteria? If it does, and it's accepted, then that claim is considered covered. But claims can also be declined outright, or they can be held. If they're held, it basically means we need more information and we'll request further information from yourselves or maybe from the client to make a decision. Once there's a decision made and the claim is covered, then we can consider funding for that injury, such as medical treatment or support. We cover personal injuries, and the specific personal injury is what we call a physical injury caused by an accident, or internally we call it a PICBA, physical injury caused by accident. And we'll kind of break that down over the next couple of slides. In addition, we cover mental injuries that are caused by an initial physical injury. So those mental injuries could be sustained, as I mentioned, because of a physical injury, because of a criminal act, such as a sexual assault, or from an event in the workplace. We also cover some different types of injuries, which you may have heard of before or may not. One of them is a work-related gradual process injury. So that might be someone like a floor layer who's diagnosed with a prepatellar bursitis because they're constantly repetitively kneeling. And also maybe relevant to yourselves, we cover treatment injuries. And they're defined as injuries that have resulted in physical harm to the patient by a registered health professional during their treatment. But there are a couple of exceptions here, and treatment injuries can't actually be covered if that physical harm was a necessary part of treatment. So if a patient was having surgery to remove a tumour and you had to cut a nerve to get to that tumour and that left the patient with nerve damage, then that would be considered a necessary part of treatment, and that's not covered as a treatment injury. Similarly, if there's an injury that's a normal consequence of treatment, so if a patient had widespread maybe diabetes and they had atherosclerosis and they got a wound infection after having a skin lesion removed from their toe, given those underlying diseases, that infection might have been an ordinary outcome because even with the careful surgery, because of their background. And so ACC cover here would actually be very unlikely. So there are kind of 2 exceptions to the treatment injury. Finally, ACC now covers nearly coming up to a year. We cover maternal birth injuries, and they're maternal birth injuries that happen either during kind of the process of labour or delivery. And that's a lot of things we cover. So if you do want more information around those, just click on the links to those slides and they'll be distributed after the presentation. So we talked about things we can cover. The legislation is quite clear also of what we don't cover. And so we as ACC don't cover medical conditions or sicknesses or things caused by aging or pre-existing conditions. In addition, ACC can't cover things like stress, so maybe stress from workplace bullying. And we also don't cover things that happen over periods of time, a non-defined kind of long period of time, unless they're work-related. In addition, which might be applicable to some of you today, we don't cover most hernias. However, there are some guidelines on the website, and I will give a little hernia example in a few minutes. Great. So we talked already about ACC covers PICBAs, which are physical injuries caused by an accident. And when we say injury, what do we mean? So an injury has to have evidence of physical damage. So that means a cut, a burn, a fracture, a muscle tear. Or in the case of a physical injury, it's clearly defined in the legislation as clinically significant behavioural, cognitive, or psychological dysfunction. What's really important to note is that symptoms, so pain, numbness, weakness, dizziness maybe, they're actually not considered evidence of a physical injury. There has to be something that we have evidence of physical damage. And coming back to that concept again of PICBA, physical injury caused by an accident. We've already discussed what the injury is, but it's worth noting that the legislation is actually pretty prescriptive as well about what an accident is. So as I mentioned already, AC doesn't cover things that happen over a period of time that's not defined. So an accident has to be an injury event or a particular series of events which involve either an external force to the body. So that's something like maybe sustaining a burn from hot water, or a sudden movement of the body, so such as pivoting your knee to get out of the way from something being thrown at you. And they're kind of two kind of accidents that happen at that moment in time, or there could be a series of events that happens over a particular period of time. So that's something that's usually unusual for the patient, and that might be something like chopping wood over the weekend. So that's your defined period of time, your defined mechanism, so chopping wood, and that eventually leads to a shoulder sprain or a rotator cuff injury. And that's our kind of series of events. And so when we're trying to establish if a physical injury is caused by an accident, we have the accident, we have a physical injury. Is it caused? Are the two linked together? Then we look at causation, and that's really a medical legal concept that we use to determine whether the accident has caused the injury. And for ACC, we actually have to be confident that it's more likely than not that the accident caused the injury. So we have to be pretty sure that that accident did cause the injury. And just because someone has a temporal association, or meaning a symptom right now from that accident, so I lifted something and now I have pain, that is usually necessary, but it's not enough to say that an accident caused an injury. So in most cases, causation is pretty simple and cover will be approved quickly. I fell, I broke my leg. That's pretty clear causation there. But sometimes it's just really not as easy as that, and you'll know that from your own patients. So in these cases, we really have to be sure that the accident caused the injury. And so that might be sometimes if the injury is complex, or maybe the claim was lodged late, like a year after the accident happened. And that's why we have things like consideration factors, which we designed with different areas of the sector, such as with RACs, which we developed hernia consideration factors, which give guidance as to what things we consider more likely than not it's caused by an accident. Or with the orthopedic group, we created some consideration factors for labral tears of the hip. And those kind of documents, what we want to think about is, if, let's say, for example, we're thinking of inguinal hernia, what was the accident? So did the patient actually report a single one-off event, a strenuous event, probably in that instances, that caused the hernia? What was the mechanism of the injury? So were they doing something that caused them to strenuously move? What were the initial consequences? So was it really clear, and is it clearly down in your notes that the patient had significant groin pain straight after that injury, and they had to straight away stop what they were doing or stop pretty soon after? And then how are the physical signs and then the patient's symptoms related to the injury? So when the patient presented to you in your physical exam, was there groin tenderness? Was there a lump in the groin that previously wasn't there? And then also important when you're noting all these things to us and you're trying to prove your point that it is that your patient should be covered by ACC and that there is causation here, it's also worth noting the pre-existing issues and how this might impact their recovery. Because once we have the whole picture, it's easier for us to make a decision. And so and then also to plan treatment. So if patient was a smoker, they had high BP, maybe blood pressure, how might this impact on their recovery? And that's also important to note. And I think Kylie, you'll probably note that a bit later. So that's it for me for now. I'll hand over to Kylie, who'll talk to us about delivering services.
Thanks, Emma. So there are two more common ways that you may deliver services for ACC under our clinical services and elective surgery contracts. So our clinical services contract can be held by you as an individual provider, or it can be held by an entity with named providers delivering the services. It's a referred in service, so it does require an accepted ACC claim and a referral from a registered health provider. We can also refer patients directly to you. It cannot be used for an injury that's being managed acutely or within 6 weeks post-elective surgery discharge. Contract covers things like initial and follow-up assessments, along with pre-op assessments, second opinions, procedures, diagnostics, and we also have some lengthier assessments such as medical case reviews. You're required to submit clinical notes to us after each service, and some of those procedures may require prior approval. Our elective surgery contract's held generally by the hospital, and it has named providers delivering the services. The contract has set prices for around 450 surgical procedures, and we call those our core procedures. For procedures without a core code, we use non-core surgery. So this requires a detailed breakdown of the components, so things like theatre time, ward stay, consumables, and we fund each of those components at a set rate. So under elective surgery, we fund the contract holder for these procedures, and they decide how to distribute the funding. And the funding is for a package of care, so it goes from admission through to 6 weeks post-elective surgery discharge. Most elective surgery requires prior approval. There are 43 procedures that can be performed without approval, and these can be found in our elective surgery operational guidelines, which are available on our website. Cost of treatment regulations is less common, but it may be suitable for you if you're not seeing ACC patients often, or you're not a named provider under a clinical services contract. and it is a contribution towards treatment, and so the patient is often required to make a co-payment. So how these services translate to working with your patients. The patient will be referred to you for a specialist assessment of a covered injury. You'll perform an initial assessment, which includes the taking of the medical history relevant to the condition, an examination of the presenting injury, confirming the diagnosis, which also includes reviewing and updating if required. We'll arrange access to necessary investigations like high-tech imaging, provide education to the patient about caring for the injury and the expectation of recovery. You'll also complete a treatment plan. And treatment plans should include the current diagnosis, the expected duration, the anticipated treatment, and the patient's capacity for return to normal function or employment. Following the assessment, clinical notes will be forwarded through to us, and this commonly is a copy of what's sent back to the referrer. The next steps will depend on the patient's treatment plan, but some possible options may include a discharge back to the referrer with an opinion on the condition and recommendations, a referral for a second opinion, a non-surgical treatment request, so things like clinic or in-room based procedures, or a surgery request. So we're going to talk about the assessment report and treatment plan, also known as the ARTP. And this is the form that's used to request all surgical procedures that require prior approval. This form will be completed by you following a clinical services assessment, and then it is forwarded on to the elective surgery supplier. And this is normally the hospital where the surgery is going to be performed. That supplier will review and submit to us for approval. Now, as I said before, there are a small number of surgeries that don't require prior approval, so those cases can be sent directly to the elective surgery supplier to proceed. The clinical notes that you've sent to us following your clinical services assessment will confirm the patient's intended surgery, and we use that to help us set up supports for clients, so things like weekly compensation. Once we receive the ARTP, we triage it. And this is performed by non-clinical staff, so it's really important that the ARTP is clear and easy to understand. If the request can be approved at this stage, we will issue the decision. If it needs more information, we'll proceed to what we call assessment. We may request clinical notes from other providers who have been involved in the patient's care, so like the GP, the physio, lodgement notes and radiology. This can take a lot of time. We may also seek clinical advice on the request, and we use our internal clinical advisors for this. We communicate our decision to your patient and to the elective surgery supplier, who will share that with you. So the ARTP contains several important sections, and it does need to be completed in full. So the history, ensuring that you explain the mechanism of injury in detail. A clear causal link statement. So this is how the accident has caused the condition requiring surgery. So an example of this might be the wrenching injury when holding onto the rope of the ski biscuit has resulted in a rupture of the ulnar collateral ligament of the left thumb. Now, like Emma said, if there are pre-existing factors, make sure to explain these. It's helpful to describe their relevance or their contribution towards the patient's condition. Make sure that you attach all relevant documentation. So your clinical notes, the radiology, a copy of the referral to you. Basically, the more that's there, the less that we may need to request. And don't forget the prognosis section. So this is really helpful for us to understand what the patient may require post-surgery. So things like vocational assistance, physiotherapy, home help. So our surgery requests have two categories of priority, high and routine. And high is broken into 4 subcategories that you'll see on the right there. So clinically urgent, where home help's required to assist with activities of daily living, the patient's receiving weekly compensation, or the patient's at risk of losing employment. And our surgery suppliers have performance measures in their contracts for timeliness. So this includes that high priority surgeries are performed within 30 days of our approval and routines within 6 months. Often surgery requests are for accidents that predate the injury or don't match the claim. So if you are seeing someone under a recent claim but diagnosing an injury that's attributable to a previous accident, or the accident doesn't match the one on the claim, then find out the correct claim details and put this on the ARTP. This saves our teams a lot of time. Timeframes for processing ARTPs can vary quite a bit. But ultimately, the better the quality of information on the ARTP, the quicker we can issue a decision. If we do need to proceed to assessment, it can take quite a lot of time to gather all of the clinical information that we need from other providers. And as a general rule, approvals are issued much quicker than declines. When we do decline to fund a surgery, we communicate this directly to your patient via a phone conversation, and then we follow this up with a letter. The letter is also emailed to the surgery supplier to share with you, and this may also contain our internal clinical advice. If you don't agree with the decision, you can write to us with further rationale for us to consider, and the patient also has review rights. This is outlined in their decision letter, and they have up to 3 months to lodge a review with ACC. I'll hand over to Peter now to talk about medical certification.
Thanks, Kylie. Okay. So we're now going to talk about recovery at work and why we want as many Kiwis as we can have to recover at work, be it in light duties or alternative duties or for smaller lengths of time. There's good evidence that returning to work improves outcomes, and work is generally good for your physical and mental well-being. And we also know that long-term work absence or work disability has a negative impact on a patient's health and well-being. So in general terms, the more your patients understand about returning to work, be it part-time or alternative duties, the more likely they are to optimize their recovery. And you as medical specialists can have a significant influence on that person's work recovery and setting the expectations for them. Most employers, so ACC has done a lot of work with their intelligence with employers and going out and speaking to employers. And most employers in New Zealand are happy to discuss alternative duties or reduced hours for their employees. And we have a lot of resources available to help employers help their employees return to work. We also can support them in many different ways. I'll come to in an additional slide, but there are many positive parts to returning to work in the work environment. Social connectedness, feeling like they're valued, maintaining the skills that they've got, and so on. There's another myth that's commonly thought of, that in order to get 80% of your pre-injury income from ACC, that you have to be fully certified fully unfit, and that's not correct. It is if you are either fully unfit or fit for selected duties, you'll get an 80% minimum pay from your pre-injury income. However, if you're fit for selected work and you're able to attend some number of hours, then ACC will abate that, in other words, add additional payment that may get you closer to that 100% of your pre-injury income when you're fit for selected work. There are many different things that ACC can do to help your patients to recover at work. We've got many different rehabilitation programs using the support of physiotherapists and occupational therapists. We also have many different types of equipment that we can support your patients, and different technologies as well. We can support your patient to and from their workplace. We can do occupational workstation assessments to try and work out whether your patient may have additional needs or supports that we can help them with. If it's unclear what their functional capacity is, we can get a physiotherapist to assess them from a functional point of view. And more, not so much for you as medical specialists, but if you have GP colleagues, also know that we can get a vocational rehabilitation review with an occupational physician to look at any additional rehabilitation that we can offer for your patient. In terms of work certification, what we're wanting is to understand what your patient is able to do. What is their capacity to work? It's ACC's role to work out with the employer, based on what you tell us about what their capacity is, to work out whether they can offer alternative duties or reduced hours for the employee. So we're asking you that you tell us about their capacity. We're asking that you assess that person's ability, tolerance, and risk. So what can they do from a physical and mental capacity? How long can they do it for? Do they need reduced hours, etc.? And are there any risks that you can identify that may be relevant, that may be put them at risk if they return to their work environment, either to themselves, to their workmates, or to the general public? That may be particularly relevant for someone who might be on strong medication and struggling with making decisions that certain environments might not be in their best interest. So we're asking, and this is something ACC has been socialising over the last few months, to, when you're filling out the work certificate, work out whether they are fit for selected work, fully unfit, or fully fit. If they're substantially able to return to their pre-injury job, then they are fully fit. If they are able to attend active rehabilitation, such as with a physiotherapist, then we would suggest that they were fit for selected duties. ACC has 3 criteria by which you consider someone to be fully unfit, and this may be relevant if a patient's just had surgery. So they have a total inability to work because they're either admitted to hospital or confined to bed. And so there may be a period of time by which they were classed as fully unfit post-surgery. But the second type of criterion is whether there's a contagion risk or quarantine need. And in this situation, an example might be a person has an external fixation device, but they work in an environment which may cause risk of infection. And the third situation is where there's a work hazard or workstation which puts them at risk either to themselves, to their co-workers, or to the general public. So as I've mentioned, we're asking you to determine whether somebody is fully unfit, fit for selected duties where possible, or fully fit. Now, when you may be handing over the care to a general practitioner, we ask that you provide as much information to them as possible so that they can then work out whether that person is able to be fit for selected duties. So we really ask that you are as prescriptive as possible when handing over that care back to the general practitioner. That's all I've got. Oh, and the last thing is that there are many resources on the ACC website in relation to the work certification. I'll talk about that a bit at the end, but please consider going to the website because there's many new resources available. I'm going to hand back to Emma now, who's going to talk about some of your responsibility in terms of cultural safety. Thanks, Emma.
Thanks, Pete. I know you've done a lot of work in that area the last while. One of the other areas that we like to talk to you tonight about is some of the responsibilities under these contracts, so clinical services and elective surgery contract. Specifically, I guess one responsibility, which is that this year, back in April, we launched our ACC new cultural safety policy, and that's called Kawa Whakaruruhau. And this policy was designed with the sector as well, and it kind of weaves together Te Ao Māori, but also non-Māori worldviews and knowledge and practices And it basically sets out our expectation on cultural safety across not just clinical services and elective surgery, but across all ACC funded services. And the hope is that this policy will help you in delivering culturally safe care to our Kiritaki or clients and their whānau. So probably worth noting here that there is a difference, or the difference between cultural competence and cultural safety. So, and how they're, important to ACC's Kiritaki. So cultural competence tends to be a focus on the culture of your patients and ensure that you've got the skills and the knowledge to understand their culture and to treat them respectfully and treat people respectfully from different cultures. Whereas cultural safety is more about yourself. So it's more about looking within yourself and examining the potential impact of your own culture and how that impacts your own kind of clinical interactions. So while cultural competence is kind of that knowledge that you have in other cultures, cultural safety and what this policy talks about is that ability to look within yourself and think how that impacts your own practice. And it's a little hard. And so we also have, alongside the cultural safety policy, we also have some guidance. And our guidance here is called Te Whānau Māori Me Mahi. And that basically, whilst the policy is the what, this guidance, it kind of tells us the how, and basically gives you lots of prompts which helps you to do that reflection and to look within yourself, and to look at your practice and your organization that you might work for or be part of kind of the leadership team. And that might, some of the examples that are in that guidance are things like, have you looked at or asked or reviewed the needs of the population that you serve in your area? And have you changed maybe things like the location of your clinic, the timing of your clinic, the availability of the services to suit the preferences of the people that you treat? And have you asked Kiritaki or your patients and their whānau about their preferences for things like receiving information? So you give someone a diagnosis, how do they want to receive that information within their consultation and following up from that? So that's just a couple of examples, but there are many within that document. And yeah, I think it's pretty awesome. And so it's good to look at them both together, is what I'd recommend. And there are some links there that'll be sent out with the slides. Great. So that's it for me. I think we have some time for some questions, which I think you'll take over, Hamish.
Yeah, thanks, Emma. Yeah, so this is your chance to ask questions or patai. Feel free to drop them into the Q&A function. So you'll find that on the top ribbon there, the little Q&A button. If you want to type in and publish that, then we'll pick it up and do our best to answer it. We have had a couple of questions come in when you registered for the webinar, so we might try and cover those now. So the first one for you, Kylie, is around what if I want to work in the private and the public setting? Could you take that one for us?
Yeah, thanks, Hamish. So yes, we can set you up to work both within Te Whatu Ora and with private suppliers. We do have quite a number of specialists that work across both and also work across multiple surgery or clinical services suppliers as well. So our health procurement team can help set you up like this, and the links to contact them will be on the end of this slide pack that's sent out afterwards.
Great, thanks, Kylie. And another question for you, just around the timeframes that people can expect for ACC to make decisions on surgery requests.
Yeah, sure. So approvals are usually issued within 10 to 12 days. Bear in mind, ACC approves around 85% of all surgery requests that come in. The ones that go on to assessment, they can take a bit longer because they're obviously dependent on us gathering clinical information from other providers and sometimes seeking their internal clinical advice. So those ones usually come through within 1 to 2 months. But obviously there's complex requests that may take longer, historical injuries take longer. I think the important message here is, though, that the better quality information we receive at that first point, the quicker we can issue a decision.
Thanks, Kylie. We have had a question here around the use of cost of treatment regulations and the clinical services contract. So, for example, I'll just read the question out. Some of our clinicians work in different sites and can see acute trauma. Can they use the clinical services contract in one site and then bill under regs, cost of treatment regulations at a different site? I have put some information in there, Mark, in the Q&A section, but Kylie, would you be able to talk through this scenario as well?
Yeah, so I'm going to make the assumption here that this is more sort of the acute trauma working with sports teams rather than acute being in the public system. So that can happen. You can use cost of treatment regulations when working with sports teams if you're the first one to see the client at that point of injury. And I think Hamish is, I can see that answer there as well, that we do have guidelines on our website around working with sports teams. And then, of course, you can use the clinical services contract to invoice for those consultations at your other site where patients are being referred in with a already accepted claim.
Thanks, Kylie. Yeah, and also just to touch on that acute funding bucket. So for acute presentation, which is usually to a public hospital, that's funded under the Public Health Acute Services. So that's ACC pays money to the Te Whatu Ora to deliver those acute services. And there are a number of rules around what is acute versus non-acute. So you may have heard the 7-day rule around surgery, where if it's urgent and acute and needs to be done within 7 days, that surgery would be funded under the Public Health Acute Services funding. If it can wait, and that's that kind of 8-day mark, then that's what we could fund under the elective surgery contract. We do have one question that's come through around what happens if I don't agree with the decision that ACC's made when requesting surgery. I think I can take that one for the team. So if a client's unhappy with a decision that we've made, the first step is for them to contact the ACC person that they've been dealing with. And they'll find that contact in the letter that they've received with the declined decision. So that'll explain more about why the decision has been made, but it'll also give information about how the client can lodge a review. So all decisions that ACC makes, the client or our karataki have the right to review that decision. If they lodge a review, then we'll take another look at that decision. And our review specialists will work with the client to help resolve the issue. And in some cases, that will be there may be additional information that we haven't received that can be sent in, and we'll consider that new information, and it may be that we're able to change the decision. I think the point that Kylie made earlier though, is the better quality information you provide up front in that request, and the more supporting information you're able to provide with us gives us the best chance to make a quick and correct decision. I think we've got another question, or another couple of questions that's come in here. So is there an affiliated program with ACC as a preferred provider? And B, in the event of an injury that happened following a surgery that requires immediate surgical attention, can ARTP approval be done retrospectively to cover hospital costs associated with that? So maybe, Kylie, I think if I can get you to take this one. Is there an affiliated program with ACC as a preferred provider?
No, we don't have an affiliated program. We just have contracted providers that are available.
Thank you. And in the event of a treatment injury that requires immediate surgical attention, can ARTP approval be done retrospectively to cover hospital costs?
Yes, completely. So there is a provision in the surgery contract for what we call significant complication or transfer of care. And what happens in those scenarios is that post the surgery, the surgical supplier will submit that retrospective ARTP to us. They will use what I referred to earlier as that non-core codes, and we will look at funding that. We will fund it under a different purchase order as well, just so we can keep track of that on the claim. But yes.
Thanks, Kylie. And another question here around treatment injury. Can you explain what constitutes ordinary consequences of the surgery covered by ACC? What's not? Or ACC covers all complications. What is the threshold used by ACC? Percentage of chance of complications occurring. Emma, would you be able to take this one?
I can start, and then I might hand over to Pete as well to comment, if that's okay. So ordinary consequences of the surgery covered by ACC. So ordinary consequences are not covered by ACC to start off with. What is considered an ordinary consequence depends, number one, on the surgery that's being performed, and number two, on who it's being performed on. So an ordinary consequence for me following particular heart surgery might be different versus another person. ACC does not cover all complications for that reason, because some complications might be more likely in some patients that have other predisposing factors. In terms of a threshold used by ACC, we do come back, as far as I'm aware, to that concept of, is it more likely than not caused by the accident? So we come down to that. Is it more likely than not caused by something that's predisposing them to this particular complication or not? And Keith, I might just ask if you've anything to add to that.
Yeah. So in fact, so if you go back to the first principles of a treatment injury, you start off with, has there been a treatment by a registered health professional? Then the second question is, has that caused a physical injury? Once you work out that you've got a physical injury caused by treatment, then the first step is it necessary? So the surgery of an appendectomy, that would be all of the parts of that would be considered a necessary part. Then you move to a series of exclusionary criteria. Now, when something is not ordinary, that's a High Court definition, and it says that something that's not ordinary is an outcome out of the range of normal outcomes that occasions a measure of surprise, taking into account severity, duration, knowledge known at the time, patient factors, surgical factors, without the benefit of hindsight. So it's in terms of providing you with a percentage, the High Court specifically said you can't use fractions or percentages. but you can start in that situation. So when we talk about incisional hernias that are is the incisional a necessary part? Is the incisional hernia a necessary part of treatment? And the answer is no. Is it an ordinary consequence? Well, a portside hernia may have a very low incidence in the literature in normal circumstances, but say a laparotomy may have high incisional hernia rates. So, and then you have to add in the patient's BMI, smoking history, any other medications that may affect the wound healing, etc. So it's a little bit more complicated than simply having a number. I hope that gives you some understanding of that. I'd be happy to talk offline in the future if you did.
Yeah, thanks, Peter. I think the thing to remember is it is really complicated, and we don't expect you to remember all of this. I have dropped a link into the treatment injury lodgement guide. I think the key thing is that to remember is that we do consider these, so you lodge it and we will guide through about the information that would need to make that decision. Hey, it looks like our questions have started to dry up, so I think we might wrap up the questions section there. Thank you very much for those really good questions that have been shared with us. I will pass over to you, Peter. Thanks.
Thanks, Hamish. So the last kind of key thing really is the resources. So in the last 2 years, ACC have spent a lot of time trying to develop content that improves the user journey and is easy for you to get to in different ways that you get the information you need to help your patient. So we do that with YouTube clips, which are indexed to help you get to the part of the YouTube clip that you need. We have webinars, we have a whole lot of different content and quick versions. One in particular that is memorable to me is the maternal birth injuries document. That's a quick guide. It has things like the different covered maternal birth injuries and the read codes that you could use. It has information around the types of signs and symptoms that you can give to your patients to help them understand their problem. They're very, very useful documents. So if you haven't been to the ACC website for a while, then I'd encourage you to go and spend some time on there. And if there is additional content that is specific to your discipline that you think would be useful, or you are interested in your discipline having a specific session, then please leave that in the feedback so that we can arrange to do that. We really want to help you develop your ACC literacy, as I call it, to try and, which ultimately will help Kiwis understand ACC better. So that's the last slide relates to some key contact things for us that you can get in touch with us if you have any questions. Are there any final questions or comments or anything you'd like to ask before we wrap the session up this evening? Okay. Well, on behalf of the team this evening, thank you all so much for giving us your time. Please send us feedback, and kia ora and ka kite. Have a good evening. Thank you.